Apparently, Dr. Janki tells me that this is our 250th webinar.
Wow.
So,
Yes, sir.
so,
Ashok sir has also joined, sir.
so this
Hi,
is a
sir.
landmark.
Hi, Ashok.
Hi, Ashok.
Hi, sir.
So this is going to be something special with Dr. Vikas Agashe talking to us today again. And it's going to be about various aspects of infection, starting with the Tendo-Achilles. So over to you, Vikas.
Just
Thank
before
you very
sir,
much.
Yeah, so let's Ashok give his
just
Yes.
before sir starts,
Yeah.
I think
Yes.
today is very, very special day, and like sir said, we have completed 250 episodes. I don't
Wow.
think any other orthopedic webinar has completed such a long run. It is more than 5 years now that it has been running and running smoothly. I think that shows the organization power of OREF with John sir and Janki at the helm. They have run it so smoothly, and the topics that is covered are such variety of topic, in-depth topics. The speakers from all across the country, all across the world. I think this is an amazing feat for all of us to witness, and we are happy to partner with OREF for doing this. So thank you very much, sir, for opportunity, and over to Vikas sir for
Thanks,
his talk.
Ashok. I think without OrthoTV, this would not have been possible.
Yes.
So,
Yes.
Thank you.
Great. Thanks.
Congratulations to OREF. Congratulations to Dr. John and Janki. And a big congratulations to Dr. Ashok, Shyam and Neeraj Bijlani for starting this
Absolutely
unique facility to take science all over the world. Well
Thank
done,
you, sir.
Ashok. Well done, Ashok and Neeraj.
Thank you.
And I'm also very lucky that I will be speaking on this 250th episode. So thank you very much for inviting me for this episode.
Well,
Wonderful.
Thank you.
Thank you. Thank you.
You engineered your COVID for this. No?
Yes. Yes. So friends, as usual, I would like all of you to expose yourself. Don't please stop your video. Open your videos.
Good evening,
Let's
sir.
have a discussion.
Yes. Okay. Rishu, Rajan.
Rajan, we have
Dayan.
met, I think, earlier. Rajan, have we?
Yeah.
Rajan, we
Yes,
have met
sir.
earlier. Dr. Dayanand,
Yes, sir.
Rishu also have we met?
Yes, sir.
Good evening, sir. And Ratan Kumar Gupta, please unmute yourself and open your video.
So Vikas, you can start, I think.
Yes.
So that we don't.
So let's start with the first thing, Shah. Can you tell me a few things about Tendo-Achilles? Gastrocnemius soleus complex. You can unmute yourself.
This is for you, Sudipta.
So let's start with the basic anatomy, differences between gastrocnemius and soleus, and any peculiarity about the tendon.
So it is the thickest tendon of the body.
Good. Anything else? Any differences between gastrocnemius and soleus? Rajan? Dr. Dayanand, please unmute yourself. Rishu?
Sir, soleus is attached on the posterior surface of the proximal tibia, and gastrocnemius is attached on the distal aspect of the femur.
Barabar, absolutely.
So the gastroc goes through two joints, the soleus only one, yeah? Oh, well, you can
Any difference between the muscle fibers of gastrocnemius and soleus? What type of muscle fibers are there in soleus? what is the main function of soleus and what is the main function of gastrocnemius? Is there any difference? Ishan, Vikas Kumar. See, soleus is type 1 muscle fiber, right? It has plenty of mitochondria, myoglobin, and essentially it is an anti-gravity muscle. It is slow, but can remain sustained, doesn't get fatigued too soon. As opposed to that is gastrocnemius, which is white fiber, while soleus is a red muscle. Red is because of its mitochondria, right? And it is aerobic, as opposed to gastrocnemius, which is anaerobic. And it is main sprinting, sudden, quick action, but gets fatigued soon, right? So this is a combination of these two different types of muscle fibers. Now, any peculiarity about the tendon? Rajan, any peculiarity about the tendon of Tendo-Achilles? I purposely put up this figure. It is known to turn on itself this way. There is something called a twist in TA. It turns this way. That is why so many times when you do TA lengthening closed, you cut the superiorly, you cut the medial, distally, you cut the anterior, right? Okay, so let's start with a case of infected TA. I think now, friends, please start your videos. Please start your videos. Otherwise, it doesn't become a fruitful discussion. Chalo, Jisan, Vikas Kumar, Ratan Kumar Gupta, everybody, please start your videos. So this was a middle-aged patient, and his son approached me actually. Said, sir, these are reports of my father, and we have come here for osteomyelitis of calcaneum with Tendo-Achilles tear. And these were the reports. So that's the X-ray which revealed an osteolytic area here. The MRI showed complete tear of Tendo-Achilles, retraction of TA, abnormal soft tissue proximal to the tendon, and osteomyelitis calcaneum. So this was the photograph. Known case of diabetes as a non-healing ulcer over Tendo-Achilles for 4 months. Initially, it started off while he was walking, heard the katak noise after a direct hit by a rickshaw. And initially he took self-treatment, then unable to bear weight. So after about 3 weeks, he heard a snap and could not bear weight. So by then, the wound was like this. So he approached a plastic surgeon who debrided, but again within no time, there was a lot of slough. He advised daily dressing, and this is where he presented to us inability to bear weight, Tendo-Achilles tear, and that's the MRI. Now, what would you do? Starting with Jisan, what will you do?
First, we'll take a wound sample for the culture and sensitivity. I will send for the to find a causative organism, and then we'll start appropriate treatment according to that, sir.
I think your culture,
Okay.
your superficial culture swab is going to be of any use in terms of the organisms.
Pardon, sir, I cannot. Hello?
So when you take a culture from a swab of a wound, do you get any meaningful result from it? I think we've had multiple classes, and Vikas has also emphasized this time and time over again.
So suppose it turns out to be Pseudomonas, sensitive only to cholesterol. Will you start cholesterol? Or suppose it turns out to be Staphylococcus, sensitive to cephalexin. Will you start cephalexin?
No, sir.
You think it is going to be useful starting antibiotics in this case? Anybody else? Rajan, what will you do? Piyush, any suggestions?
Don't feel shy.
Debridement. Wound debridement and followed by the deep tissue swab for the culture.
And when
Okay.
when the infection will reach to the level that infection has subsided, and we'll plan for the repair, sir.
I didn't get you. Flexion?
I think, Rajan, your internet is very slow. You'll have to.
Sir, we
So
will.
the most important thing. Sorry, go ahead.
Sir, multiple wound debridements till that infection has subsided, and then we will go for repairs.
So what do you mean by multiple wound debridements? You plan to do multiple debridements, or you plan to do one proper debridement?
Sir, if that one proper debridement is enough, sir, then that can.
So your aim is to get a thorough debridement the first time. You may have to do it again. That's a different thing. Yeah.
So about 20-25 years ago, what you said was very relevant. We used to keep talking multiple debridements, repeated debridements. Today we feel that if I have to do 3 debridements, that means my first 2 debridements were inadequate. So you aim to do a full debridement. Now, before all this, in such cases, you must say that let me examine the patient well. That is the most important. Do not give any opinion. Just go through all that. Say, I will like to examine the patient first. Till then, I do not want to. I said, unless I examine the patient, I will not commit myself. So this is a video. Can you see? I am way high up. And see the pus. So, if you go through the MRI, you will realize that it was only for the Tendo-Achilles. And this is how patients of infection after Tendo-Achilles often approach. The MRI is done only of that small part of TA. And the infection invariably has traveled way proximal. Barabar ki nahi? See this video again. Dekha?
Yeah.
It's right up to there. Right up to there. So do not commit till you have examined the patient. And always examine like this. Always check whether the infection has spread proximally. So now what do we do? This is on table. The scoop is going way proximal. Up to here. The scoop is going right up to here. Now what should you do? What will be your incision? What will be your plan?
Careful, Vikas.
Don't worry, I will not transfer the
No.
virus through internet.
I think that your enthusiasm is getting the better of you. Yes, goes.
Yeah. Bolo. What would be your approach? What would be your incision? And what would be your plan now? You have an osteomyelitis of the calcaneum. You have TA tear. You have significant infection proximal in the TA. You have the entire Tendo-Achilles that is ruptured. So what would be your plan of action?
So he's marked out the incision, everything for you. So at least you can go.
Yes, sir.
Correct. So then what will you do after this? After you explore, what will you do?
Sir, thorough debridement and wound irrigation and followed by back application.
Correct. So what do you mean by thorough debridement? In this case, especially in case of a tendon, how would you debride? Tendon is already ruptured.
Yes, sir.
Right?
It's a relatively...
So fresh margin where the punctate bleeding comes out, till that portion we can...
So is tendon vascular?
No, sir.
So where do you expect punctate bleeding from?
So here you can see we have cut the calcaneum, starting with calcaneum, and try and go around that infected area and go up. That was the plan. However, especially with such a bad wound, we could not really isolate everything right in the beginning. But that was the plan. And here underneath also you can see infection. Took out that piece of calcaneum totally, and here you can see pus inside. Right? And that was the proximal extent of the pus. Dekha? So this is where we stand. Now what should I do? Should I open this, clean it up? Now generally what happens is there is a huge cavity inside with full of pus. So it is best that you just knock this off. Just knock this off. Especially with TA. See that? Underneath also there is pus. And you can see we could separate. Proximally there appeared to be a plane between the gastrocnemius and soleus. So we cut this and took out the entire part of gastrocnemius up to here. This way.
So I think what all of you must be aware of is infection in the Tendo-Achilles and calcaneal osteomyelitis are both not easy things to treat. Okay, because of the poor vascularity, you have to really do a very thorough debridement if you want this to heal. Okay, even the calcaneum can be, I've seen people operating on 3-4 times and not getting all the dead tissue out, and eventually the infection recurs and you have problems. So this is something that you have to be very careful of. Vikas, you have the same experience? Or?
Yes, absolutely. Day one, you should be able to out everything, and it is best that you go well beyond that. Then only you are able to address that. So that's the extent of excision we had done. From inside also you can see it's dirty, absolutely.
And you should not worry about what you can reconstruct and what you can't reconstruct. Your debridement has to be adequate. Worry about reconstruction later.
Later. So this is where we stand, day 1. And this is the culture report, E. coli and Proteus. So meropenem, this, that, etc., was started ID specialist. And that's post-op X-ray. And this is 4th day. Now what would you do? You can see part of the soleus still intact, but we don't have the Tendo-Achilles. We don't have the Tendo-Achilles. We have only soleus. We do not have gastrocnemius. These are the cut ends of gastrocnemius, you can see. These are the cut ends of gastrocnemius. That's the soleus, and that's no tendon at all. Nothing here. Now what should we do?
Can we reconstruct with pre-composite anterolateral flap, like taking flap from the vascularized fascia lata?
From the fascia lata. So you mean microvascular flap with ALT?
Yes, sir.
Okay, that's one good option. Anterolateral thigh flap is what you are talking of?
Yes, sir.
Thigh flap with gastronomia, with fascia lata. Any other opinion? You are right. There have been papers describing that. Absolutely. Anything else?
So what's available locally?
Which tendon below that?
Tendon.
Tibialis posterior.
Tibialis posterior. Yes.
Tibialis posterior.
Posterior. Yeah. Tibialis posterior.
Is it worthwhile sacrificing tibialis posterior? Which tendon can be sacrificed if tendo is torn?
FHL, flexor hallucis longus.
Flexor hallucis longus.
Correct.
FHL.
FHL. Absolutely right. Tibialis posterior is too valuable a muscle to be utilized for this, isn't it? Any other opinion? Any other opinion? No other opinion. Suppose I don't do anything at all.
Yeah, I was gonna.
What would happen? What would happen? Tendo-Achilles is important for what are the functions of Tendo-Achilles?
To push up while walking.
Right.
So have you seen patients with ruptured TA managing their day-to-day functions?
Yes.
So
what can't they do?
So they can't run.
Unable plantar flexion.
Or there is a sustained ankle pain during.
ankle. Okay.
Pain is not such a big feature of a rupture, yeah? The problem is...
Plantar flexions नहीं कर पाएगा sir.
Well, so what can't they do because of that functionally?
Can they go on the
running
tools?
and jumping?
Yeah, so they'll have problems running, jumping, stairs maybe,
Stairs
but
maybe.
otherwise normally they can manage to walk quite all right. I mean, have you patients with chronic ruptures, do they come to you walking or do they come to you on a wheelchair?
On walking.
Yeah. So sometimes you have to look at whether the cost of reconstruction is worth the added benefit it gives, depending on the patient's general status, age, demands, etc. Okay.
So suppose here you decide to do FHL transfer. How would you do that? Is there any prerequisite for a transfer? Any prerequisite for a transfer?
Yes. That movement should be present at the joint.
Ankle movement should be good. Anything else?
No.
Need a
Tendon
good...
should lie in the same line.
So what are you going to attach
Okay.
the tendon to? What are you going to attach the tendon to?
So
Sorry?
So you'll probably have to drill a hole in calcaneum, but you need a robust skin cover, isn't it? You need a good cover here. This part, see, upper part is not an issue. This lower part, distally, there is going to be a big gap. And area where you are going to transfer the tendon, you will need a flap cover. So you will definitely need a flap cover, correct? Now the most common flap that can be used is a sural flap. Now will you be able to get a sural flap here? Difficult. Barabar ki nahi? So you'll need some kind of flap here, and maybe you will need a dorsalis pedis flap or something like that. Barabar, it's not going to be easy getting a flap cover here, correct?
yes.
So this is 8th day post debridement, and this is day 1. This is 8th day after negative pressure therapy, and then we could proximally we could suture. Again, the question is Tendo-Achilles reconstruction. So he said, first let's tide over the crisis. He's a diabetic patient, elderly patient. Let us see how he improves. So that's 6 weeks of cast. And at 3 months, he was walking quite comfortably in a brace. He was a doctor, so he started going to his clinic. This is for 3 months. He was very, very cautious, having burnt his fingers. But by 2 years, do everything. Everything. He could climb stairs. He could do everything. This is him at 4 years. Absolutely same power. We haven't done anything at all.
When you say same power, what do you mean?
Comparing the other side.
Really?
Yeah, absolutely.
I find that hard to, I mean, they can certainly stand on their toes with both feet, but usually on one foot, they are unable to easily stand on their toes, okay? So when you say exactly the same strength, I would take it with a pinch of salt.
I know, but
yeah.
I understand. But
Yeah.
I mean,
he got back.
I'll show you 2 more cases.
I mean, I know because I treat most of mine without surgery. Most of my TA ruptures, I don't even operate on them anymore.
Right.
So, I mean, I
Somehow,
know so they get back a very good function. But
yes,
to say that it's exactly the same as the other side, that is like
overstatement.
If you actually examine them and do a muscle power thing, you'll find some difference usually.
See, especially after infection, somehow they get
the fibrous
very good
tissue,
power,
etc. forms.
as opposed to non-infected area or non-infected cases.
True.
So this
I mean,
was,
but the point is very clear that you don't always have to reconstruct these. Yeah.
correct, correct. So another one exactly similar. She was repaired and with a fiber wire, and here you can see almost similar thing. All the metal foreign bodies are out. Suture, anchor, and tape. Gap of almost 6 to 7 centimeters. Exactly similar thing. That 1 month, and initially they are little careful, but over a period of time, another one. So at least this, the power was almost same.
So almost the same, I have no trouble accepting.
Okay, I change my words to almost same. So that's the score. So most of the patients have a pretty good function, and there is no need for reconstruct after infection. We are not talking about clean cases.
No, but even with clean cases, I mean, in the sense that you're talking about ruptures, okay?
Yes.
Acute ruptures, a lot of them we treat without surgery nowadays.
Correct, absolutely. So every time there is no need, even though TA has a very important function, every time one doesn't have to do that. So this is a very large paper, 20 cases between 2000 and 2016. And especially because of significant fibrosis, they developed decent stability, and all were able to walk without any kind of aid. And most patients reported that their overall function was normal or nearly normal. So this is a paper where they have proved that the Tendo-Achilles has actually regrown with the MRI and ultrasound. After about a year or 1.5 years, the Tendo-Achilles had grown. So that's, we haven't done ultrasound or MRI in our cases, but that's an article.
So that used to happen with the German in that camps that they used to cut off the TAs of a lot of the prisoners so that they couldn't climb up the wall. And within 2-3 weeks, these guys would be back to jumping over walls, etc.
So first and foremost, good clinical examination. That is the most important thing. Don't take MRI at face value. Invariably, in these cases, the infection has spread way proximal, and you have to plan your incision accordingly. You can't just think of a local surgery. Then again, there's nothing like repeated debridements. It has to be preferably in one go. Second look surgery is only for, say, closure or insertion of local antibiotics, so on and so forth. And because of extensive fibrosis, in spite of aggressive excision, reconstruction may not be needed, or in fact, generally not needed. Of course, there are papers, but very few, where people have reconstructed it using an FHL. And but of course, a flap cover is vital. Yeah. Any questions?
Oh, great. I think this is really important because we do see a few of these, and we haven't had to reconstruct, or we haven't reconstructed in these infected cases so far. And the only thing is, we haven't really tested them that closely for the function, as a lot of them don't come back, and we haven't, but all of them are walking without aids. You're right about that.
Correct. So we assess there. It was quite good, 85 points out of 100.
Exactly.
So that was pretty good.
Sir, in fresh cases, what you do?
So what are you talking about? Fresh cases, open or closed?
Sir, in fresh cases, when with patient
Fresh
is old
case,
and diabetic,
I think
chronic tear repair with at least 5 centimeter gap, then what should you do?
no. So the way we look at it is, if they come to you late with a significant functional disability,
Yes.
okay, then we would think of a reconstruction. In the fresh cases, my standard treatment is to put them in a sort of, what do you call it? A walking boot in equinus. Okay, and gradually reduce the equinus till they come to neutral, and then let them walk. So that is, now if in a young athletic person, your approach may be different, okay? So in a sportsman, your approach would be different. The majority of these chronic...
Sir, what about the open tear rupture in acute?
So if it's a cut injury, lacerated thing, obviously you'd go in and repair it, okay? But if the wound is bad, you still... So some of these, that area, especially in the diabetics, is a area where infection is very common when you do reconstructions. Okay, wound problems is not uncommon. So Vikas,
yeah.
So what would
Couple of things. One is I'm extremely scared of doing a late repair with a gap in case of diabetics.
Yeah.
Wound problems are plenty. So as Dr. John said, that unless patient comes with disability, they find it difficult to walk, best way is not to do anything. Just because there is a gap and there are khadda lagta hai, but I am able to do everything, forget it. Number two is post-injection ruptures. Invariably, the local blood supply is poor because they have started off with a vascular is there, and with an injection, one day they suddenly rupture. Again, the area of necrotic muscle is significantly high. So unless patient is young and non-diabetic, I would rather think 10 times before repairing. And more cases of these those sutures, suture anchors
I
are
think
coming in.
Yeah, people are going overboard with these suture anchors and repairs, and honestly,
they're very troublesome. They're very, very troublesome.
All they
and they are deep inside the calcaneum. Invariably, I mean, the infection rate is quite high. You need to take out a large amount of calcaneum, large portion of calcaneum.
Yeah, I think that's something we have to keep in mind, the infection rates, and just be very careful about these cases. They are not ones that you just operate. And we've done a lot of reconstructions, but we are really careful about the wound closure. And if there's any tension, we really try to avoid doing these kind of major reconstructions.
Correct.
These diabetic especially. Okay, Vikas, I think we should let you go. You're coughing a bit much, so you need some rest. Thank you very much.
Thank you very much. Thank you.
Great.
Okay. And congratulations for the 250th episode. Ashok, thank you for being here. And thank you all. Thank you, boys.
Thank you, sir.
Thank you, sir. Thank you.
Bye-bye.
Bye, everybody.
Bye, Janki.